Once upon a time, there was a small village in the mountains where people lived a simple life. In this village lived a woman named Layla. Layla was in the prime of her youth. She started to suffer from a strange condition that puzzled the villagers. She started to feel extremely tired all the time, even though she didn't do much. She also started to gain weight, even though she was eating less. And she felt cold all the time, while others felt warm. The villagers thought that Layla had been cursed or affected by evil spirits. They took her to wise men and healers, and they tried strange treatments. But she didn't get better. In fact, her condition worsened over time. While it wasn't clear at the time, Layla suffered from a medical condition called hypothyroidism. So what is hypothyroidism and how to approach these patients? That's what we're going to talk about in this lecture. I'm Dr. Ali and let's begin. Now, hypothyroidism is a clinical state resulting from underproduction of the thyroid hormone T3 and T4. Thyroid gland is a gland located at the anterior part of the neck and responsible for producing thyroid hormone T3 and T4. What is the function of thyroid hormone? Thyroid hormones act on nearly every cell in the body. It acts to increase the basal metabolic rate, affect protein synthesis, help regulate long bone growth in synergy with the growth hormone, increases the body's sensitivity to catecholamines such as adrenaline, and it is necessary for neural development, especially in fetuses. How it's regulated? The hypothalamus secretes hormone called thyrotropin-releasing hormone, TRH, which travel to anterior pituitary to release thyroid stimulation hormone, or TSH. This TSH affects the thyroid gland and make it release thyroid hormone T3 and T4. Now T4 has longer half-life, around 1 week, but T3 is the more active form. Most of these hormones travel in the blood attached to globulin. This globulin called thyroxine binding globulin, or TBG. Keep in mind that just the free form gets inside the cell to give its effects. Inside the cells, T4 converts to T3 by enzyme called 5-deiodinase. Once the hormone in the blood, there is a negative feedback to hypothalamus and pituitary gland that causes either to increase the secretion or decrease the secretion of TRH and TSH. So, any abnormality in this process can lead to abnormal thyroid function test. What are the types of hypothyroidism? Primary hypothyroidism. Primary hypothyroidism is a disease accounts for over 95% of cases of hypothyroidism. It is due to inadequate production of thyroid hormone caused by disease of the thyroid gland itself. Central hypothyroidism. Central hypothyroidism is due to insufficient stimulation of the thyroid gland by TSH, and it is caused by either hypothalamic cause, which called tertiary hypothyroidism, or pituitary cause, which called secondary hypothyroidism. Central hypothyroidism is much less common than primary hypothyroidism. Epidimiology of hypothyroidism. The prevalence of hypothyroidism or overt hypothyroidism varies from 0.1 to 2%. The prevalence of subclinical hypothyroidism is higher, ranging from 4 to 10% of adults, with possibly a higher frequency in older women. Hypothyroidism is 5 to 8 times more common in women than men, and is more common in women with a small body size at birth or during childhood. This is Amal. Amal is 26 years old. She is your neighbor and knows you are a good doctor. She wants to consult you about her lab result. Of course, you agree to see the test. Her test was for thyroid function and it shows hypothyroidism. So you ask her to come to your clinic to discuss her case. Now, how do you approach her? As a good doctor, you know how to start your approach by taking a good history. So what will you ask Amal? In order to take history for patient with hypothyroidism, you will focus on two main things. Number 1. Symptoms of hypothyroidism. What are the symptoms of hypothyroidism? Symptoms may be non-specific, especially if dysfunction develops slowly. Symptoms may include weakness, lethargy, depression, low mood, memory changes, weight gain, cold intolerance, constipation, menstrual irregularity, usually menorrhagia, hair loss, myalgia, decreased libido, and voice changes. The other aspect of history taking you will focus on is risk factor for hypothyroidism. So what are the risk factors for hypothyroidism? Female sex, middle age, family history of autoimmune thyroiditis, autoimmune disorders, treatment of thyroid disease, postpartum thyroiditis, Turner's or Down syndromes, radiation therapy to head and neck, iodine deficiency, and amiodarone use and lithium use. Don't forget when you ask about the history of the patient to ask about ICE, I-C-E-E. Each letter represents something you will ask about: idea, concern, expectation, and effect on her life. After you take a history, now you will move to physical examination. What aspect of physical examination you will focus on in this patient? First, general metabolic signs may include increase in body mass index, low metabolic rate, and hypothermia. Second, examination of the skin. You will look for coarse or dry skin, yellow palms, which is uncommon to present in hypothyroidism, and alopecia areata. Head and neck examination. You will assess for hair loss, include loss of lateral eyebrows, and periorbital edema. In the neck, you will look for goiter and examine the thyroid gland. In cardiac, you will look for cardiac signs related to hypothyroidism, which may include bradycardia and hypertension. Respiratory manifestation can develop in patients with severe hypothyroidism and myxedema coma, include hypoventilation, respiratory failure resulting from reduced sensitivity of central nervous system to hypoxia and hypercapnia. In the extremities, you could see pseudohypertrophy of muscles, which is a rare presentation called Hoffman syndrome. Also, you could see non-pitting edema. You could assess for neurological and psychiatric manifestation, including impaired cognitive function and depression, dementia, and ataxia. In severe cases, patients may present with signs of carpal tunnel syndrome. Now, after you finish the exam, the next step is to order extra lab for the hypothyroidism. Which lab you will order? Maybe you will repeat TSH and T4. You will order CBC, lipid profile, and fasting blood sugar. Let's get back to Amal. Her case is as follows. A 27-year-old female presents to the office with the chief complaint of fatigue for 4 months. She has gained 6 kg in that same time, despite a decrease in appetite. She also complains of depression, increased sleepiness, lack of energy, hair loss, and cold intolerance. Her past medical history is unremarkable, and she takes no medication. She has never had any surgeries. Her examination is unremarkable. Blood pressure within normal and heart rate regular 60 beats per minute. Her weight is 65 kg. Her CBC, fasting blood sugar, lipid profile within normal range. TSH is high 22 and free T4 is low, 0.56 nanogram per deciliter. How you interpret thyroid function test? High TSH and high free T4 means central hyperthyroidism. Low TSH and high free T4 means primary hyperthyroidism. High TSH and low free T4 means primary hypothyroidism. Low TSH and low free T4 means central hypothyroidism. High TSH and normal free T4 means subclinical hypothyroidism. And finally, low TSH and normal free T4 means subclinical hyperthyroidism. So our patient is having a primary hypothyroidism. So what's your management plan? All patients with overt primary hypothyroidism should be treated. The goals of a treatment are reduce symptoms, normalize serum TSH, prevent complications, avoid overtreatment. Treatment is given upon establishing the diagnosis and is lifelong. Treatment is with levothyroxine. The recommended dose for healthy non-pregnant adult less than 60 years old is 1.5 to 1.8 microgram per kilogram per day. If we look at our patient Amal, it's around 100 microgram per day. Special consideration. For patients older than 60 years and for patients with ischemic heart disease, we start with lower dose, around 12.5 to 50 microgram per day, to decrease the potential for adverse effect from thyroid excess. Now, thyroxine should be taken on an empty stomach with water, ideally 30 to 60 minutes before breakfast. And it should not be taken with other medication that interfere with its absorption, for example, calcium carbonate and ferrous sulfate. The separation of 4 hours is a traditional practice. Some patients take their treatment at bedtime, at least 2 hours after their last meal, which ideally should be longer. If adherence cannot be maintained with daily levothyroxine dosing, consider weekly oral administration of a full week's dose of levothyroxine. If possible, it is better that patient remain on the same thyroxine formulation. Now, let's continue with our case. After you decide on the dose of 100 microgram per day, when should you see her again? Because of the long life of thyroxine T4, assess serum TSH 4 to 6 weeks after any dose change. After adequate replacement dose has been determined, measure TSH level after 6 months and then at a 12 months interval, or more frequently based on the clinical situation. Amal returned for her appointment after 2 months. At follow-up, she reports a general improvement in symptoms, but is not back to normal. Her result is as follows: TSH 11.8 and free T4 is 0.75. What is your plan? First, you should look for causes for poor response. This includes drug interactions like calcium carbonate, ferrous sulfate, antacid, and proton pump inhibitors. Second, poor adherence, like missing doses or change in timing of medication relative to eating. Other thing you could look for is malabsorption, like celiac disease, diabetic gastropathy, and Helicobacter pylori gastritis. Now, after that, you want to change the dose. Changing the dose is individualized and gradual. The suggestion is an increase by 15 to 20% or increase 1 tablet per week. For example, our patient who takes 100 microgram per day could take on one day 2 tablets, which mean increase by 100 microgram per week. Other methods depend on TSH level. For example, if TSH between 5 and 10, small increase with a 12 to 25 microgram per day is sufficient. If the TSH is above 10, a larger dose increase is usually necessary, around 25 to 50 microgram per day. When TSH is very high, more than 20 for example, free T4 measurement can help determine an appropriate dose increase. In elderly patients or patients with heart disease, adjust dose in increments of 12.5 to 25 microgram every 4 to 6 weeks. If there is an evidence of overtreatment, which means TSH is low, if the TSH is slightly below normal, between 0.05 to 0.3, a small dose reduction of 12 to 25 microgram per day is usually sufficient. An alternative is to reduce the dose by 15% by omitting one pill a week. Lower TSH value may require larger dose reduction. Prognosis is generally excellent with full recovery upon adequate replacement of thyroid hormone. Let's go back to our patient. Our patient has been doing great for a couple of years. When she returned to see you for a routine follow-up, both her TSH and her free T4 are within the normal range. She then informs you that she had no menses for 5 weeks. You check a urine pregnancy test in the clinic and it is positive. The patient is excited about the pregnancy. Women need more thyroid hormone during pregnancy, and unlike normal women, those with hypothyroidism are unable to increase thyroidal T4 and T3 secretion. In normal pregnancy, the thyroid gland increases in size by 10% and the production of thyroid hormones increase by 50%. Placental human chorionic gonadotropin (HCG) has a similar structure to thyroid stimulation hormone (TSH) and cross-react with the receptor. This results in reduced plasma TSH level throughout pregnancy. For a pregnant patient with existing hypothyroidism, you should increase the levothyroxine dose by 20 to 30% as soon as the pregnancy is confirmed. This can be achieved by taking 2 additional tablets weekly. TSH should be measured every 4 weeks in pregnant women on levothyroxine therapy until mid-gestation, then once in each of the 2nd and 3rd trimester. TSH targeted during pregnancy is different from non-pregnant women and changes with every trimester. For example, in the 1st trimester, TSH level should be between 0.1 to 2.5. In the 2nd trimester, is between 0.2 to 3, and 3rd trimester is between 0.3 to 3. Readjust levothyroxine doses to preconception dose following delivery and monitor thyroid function at about 6 weeks postpartum. Amal friend Haya wants to consult you about her thyroid function test. She is a 25-year-old female. Her TSH is noted to be elevated at 7.2. She has a normal free T4 and is asymptomatic. You repeat the labs with very similar results. What's your diagnosis for Haya? Her lab result represent subclinical hypothyroidism. The big question with subclinical hypothyroidism is, do you treat or not? The decision to treat patients with subclinical hypothyroidism is controversial, as treatment is reported to improve markers of the disease but not the clinical outcomes. So it must be on individual basis. It's suggested to treat patients with subclinical hypothyroidism if TSH is higher than 10. If TSH level between 5 to 10 in conjunction with goiter. If there is a positive anti-TPO antibodies. If the patient suffers from treatment-resistant depression. If the patient has infertility. And in a pregnant woman. The dose of treatment for subclinical hypothyroidism is lower than usual, around 1 microgram per kilogram per day or 50 to 75 microgram per day, and then adjust the dose accordingly. Extra point. Screening. Screening recommendations for major groups are conflicting. The American Academy of Family Physicians does not recommend screening for hypothyroidism in asymptomatic adults. The American Thyroid Association and the American Association of Clinical Endocrinologists
recommend measurement of TSH in any individual at risk of hypothyroidism. For example, patient with personal history of type 1 diabetes or other autoimmune disease, if there is a family history of thyroid disease, a history of neck radiation to the thyroid, or a history of thyroid surgery. And you should consider measurement of TSH for the patient over the age of 60 years. The United States Preventive Service Task Force found insufficient evidence to assess the benefit and harm of screening. The American College of Obstetrics and Gynecologists recommend thyroid function tests in pregnant women who are at increased risk of thyroid disease. You also could consider TSH in case of substantial hyperlipidemia or change in lipid pattern. In case of hyponatremia, high serum muscle enzyme concentration, macrocytic anemia, pericardial or pleural effusion. Sometimes you could consider referral for patients with hypothyroidism. These include any patient in whom you suspect a diagnosis of central hypothyroidism, patient with pre-existing cardiac disease, patient who you suspect have an uncommon cause of hypothyroidism, any woman who is pregnant or is planning a pregnancy, structural change in thyroid gland like goiter or nodule, symptoms that do not improve or worsen after treatment with levothyroxine, if you suspect myxedema coma, and in younger patients. Keep in mind, levothyroxine sodium is contraindicated in patients with uncorrected adrenal insufficiency because of risk of Addison crisis. Also, patients with coexisting iron deficiency anemia and subclinical hypothyroidism had a greater increase in hemoglobin when given both iron and thyroid hormone replacement when compared with those who given iron alone. Patients with hypothyroidism should not be treated with iodine supplementation unless they are from an area with known iodine insufficiency. Remember, do not use thyroxine for weight loss.
To summarize, hypothyroidism is a common disease characterized by low thyroid hormones T4 and T3 secretions. When taking history for hypothyroidism, you should focus on symptoms of hypothyroidism and risk factors. Treatment is with levothyroxine and is lifelong. The recommended dose is 1.5 to 1.8 microgram per kilogram per day. In elderly and patients with heart disease, you should start low and go slow with the treatment. Follow-up is usually between 4 to 6 weeks. In a pregnancy, you should increase the dose because of the increase in requirement. The decision to treat subclinical hypothyroidism is controversial and should be individualized. To read more about hypothyroidism, there are some extra sources and articles in the description. Don't forget to like and subscribe to our channel.